and welcome Patricia Gongal, who will be moderating the session entitled A Vision for the Future of the CDTRP Ecosystem and the Role of CDTRP. Patricia Gongal is the CDTRP Executive Director. She completed her PhD in molecular biology and genetics from the University of Alberta in 2009 and a postdoctoral fellowship in developmental biology at the École Normale Supérieure in France. She has worked in a variety of roles supporting researchers and research programs, including as an independent scientific writing consultant, as a research development officer at Aberystwyth University, UK, and director of major grants at the University of Alberta's Faculty of Medicine and Dentistry, where she developed, implemented, and managed the strategy for large-scale research funding initiatives. She joined the CDTRP in 2020. So I'll welcome Patricia to now introduce the panelists for the next session.
Thank you. Thank you very much, Mel, for the introduction. And thank you, everyone, for joining us. I understand there's a very important scheduling conflict this morning with the Brazil game for the World Cup. So Manuela is going to keep us posted if there's major developments on that front. And in the meantime, we are going to discuss the equally important topic of the vision for the future of the Canadian donation and transplantation research ecosystem and the role of CDTRP within that. So the format of this session, so I will give about a 20 minutes presentation overviewing this project that we undertook with the support of many organizations in our ecosystem in Canada. And then we'll have the panel discussion. So I'll introduce our panelists right before that. And then we will have some time for Q&A and open discussion. And I really welcome comments and input from everyone in the community about the direction of CDTRP within our overall ecosystem, which by necessity requires collaboration and effective working together of all of us. So this is a project that was driven by the Organ Donation and Transplantation Collaborative and funded by Health Canada. And stems from the feeling within the collaborative that there was a lack of a unified approach to research and innovation in Canada. And this represents a major barrier to establishing system priorities for a high-performing research and innovation ecosystem. And so this project set out to clarify in detail the challenges, the needs, the roles, the responsibilities, and the interfaces of the key stakeholders in research and innovation, and to develop a shared vision of the future. So what we're really trying to get at is who are all of the stakeholders? What roles do they play in the ecosystem? What in people's perceptions are the gaps and opportunities to better work together? And where are we going in the future? And how do we get there? So the CDTRP helped with the logistics of running the project. We had arm's length consultants actually carry out the work. So that's a firm called Juniper to make sure we had a neutral sort of facilitator to ensure people were able to share their views. So the outputs of the project are two reports. So the phase one was the comprehensive ecosystem mapping, and then a phase two vision and actions report. So this project rests with the collaborative's decision-making and accountability working group, and the ODTC will take up these reports for consideration, and we'll be making decisions on the recommendations and the ownership of specific actions that the collaborative could consider. So the consultants undertook an extensive engagement and research process to understand all of the stakeholders in donation and transplantation research in Canada. That includes over 60 one-on-one interviews, reviewing documentation on over 50 organizations, and by administering an open survey to the community. They then synthesized all of that information into the map, setting out the key roles of the organizations related to research, and specifically looking at the kinds of activities that they do. Specifically, these were funding research, non-funding support for research, networking, the execution of research, knowledge sharing, and implementation. So I won't share the phase 1 report is about 100 pages long. So it's really an encyclopedia of donation and transplantation in Canada. And I'll just provide a little bit of a snapshot of what the overall map looks like. So we have all of our organizations on the left. On this slide, the different types of activities are the columns, and then the number of dots is the intensity or the level of focus of each of those organizations on that type of activity. So we have organizations that are specifically focusing on donation and transplantation, and then of course other entities which have a broader healthcare focus, not specific to ODT, but which nevertheless play a really crucial role in our ability to do research and mobilize that knowledge. So one of the key conclusions of the report, stemming from stakeholder perspectives on challenges and gaps within the system, is that while the current decentralized and distributed research landscape serves some important functions and should be retained, there was a consensus that there's a lack of strategic system coordination, and that is a problem. It was felt that the ecosystem is really an amalgamation of competing priorities where system needs can be overlooked if they're not in line with individual priorities of the entities that control access to resources. So as a result, we have an unstable environment with fuzzy mandates, insufficient funding, and gaps where the research needs of key stakeholders aren't being met. And that includes patients, families, and donors. So for a more aligned future, what the consultants heard was that there may be a need for some kind of a mechanism to coordinate or orchestrate research priorities. And there's a number of key factors that this mechanism would need to be successful, including having a wide view of the ecosystem, sufficient and predictable funding, strong leadership, and a fair and impartial process to decide on those priorities. So phase 2, so with that map and with that analysis in place, there were many people who then contributed to the phase 2 goal of generating what a shared vision for the ecosystem could look like. So that the consultants again guided the group through an iterative process to build consensus and refine these recommendations. And the key results that the community is seeking fell into three sort of buckets that align with the research lifecycle. So research prioritization, research execution, and knowledge translation and implementation. So in terms of research prioritization, what the community would like to see is that the ecosystem is effectively able to identify, prioritize, track, and support the development of key research topics and capabilities, focusing on the most acute gaps at multiple levels of government and the community, and positioning Canada as a leader in the international space. When it comes to research execution, the desire is that the execution of research is inclusive, diverse, and collaborative in terms of perspectives, and is aligned on key execution enabling factors across the ecosystem. And I'll give some examples of these factors in just a moment when we're talking about actions. And then last but not least, knowledge translation and implementation. The goal is that knowledge generated by the ecosystem is easily shared across the stakeholders. And there's a clear understanding of the pathways of moving research into action at the ecosystem level. And that this is facilitated by one entity. So you have some kind of a hub or a one-stop shop where people can go and understand what those pathways look like. So how do we get there? So the structure of this part of my presentation. So I'll show just a few selected actions that were consensus of the phase 2 committee, and then how we think that CDTRP could either lead some of these or fit in or contribute to others. And what I would love to hear from the community and from our panelists is feedback on that, and also how their organizations can fit into these actions. So for establishing a more effective prioritization mechanism, some of the key steps here: identifying key stakeholders who have visibility into that research. You need to understand what is happening currently before you can prioritize a future direction. And creating a framework for deciding how you gather that information and how you share that across the community. You need to determine the prioritization approach, which is enabling for decision making. And you need to include patients, families, and donors, and other underrepresented communities somehow in that process. Co-creating a process with Indigenous nations for their involvement in the prioritization process. And then crucially, identifying an optimal fund allocation model, considering reallocation of existing funds and ideally the generation of new funds, which you could link directly to the priorities so that you have the resources to put in place or pursue the priorities that the community deems the most important. Okay. So where could CDTRP fit into this? Well, in terms of understanding the research that's happening across Canada, we are currently supporting and tracking 125 active research projects across the country from all different funders. Now, certainly that's not all of the research happening in Canada for sure, but that's a significant amount that we're pretty proud of. So we have some sense, at least, of what's happening across the country. In terms of a prioritization approach, this is, and you'll hear one example of this in the COVID therapeutic session that will follow this morning, but we have run consensus building processes to set research priorities at the program level, and including the views of patients, families, and donors. Indeed, the themes from CDTRP were determined through such a prioritization and community discussion process, including multiple stakeholders. Co-creating a process with Indigenous nations. We have numerous CDTRP members who are Indigenous and who would be well positioned to do that work. What CDTRP could perhaps do is support them in doing that work. What I've heard from some of our Indigenous members is that the lack of human resources for things like planning events, coordination, all of that very important work that makes events happen, processes happen, is difficult to undertake because of a lack of resources. So perhaps that's one area where CDTRP can contribute. And then lastly, an optimal fund allocation model. Well, that's a big question, and CDTRP certainly doesn't have the resources to fund research. However, what we have done in our innovation grant program is build a network of partners who can contribute to an open, competitive funding program on their own terms in a certain sense. So respecting different organizations' mandates, their governance, their own priorities, but nevertheless, how they can contribute to a single funding program. So how could that be considered within the opportunity to do something much bigger nationally? Okay. Then actually doing the research or the execution phase. So The recommendations of the committee, or a few of them, are here. So first, developing recommendations for a unified standard for patient, family, and donor partner participation in research and innovation. Two, identifying gaps in next generation researcher development. And three, identifying a group or organization to take on the coordination of an ODT research ecosystem data strategy. So what could CDTRP contribute on this front? Well, we have our patient, family, and donor partnership platform. We have terms of reference for engaging patient partners, which are continually evolving as best practices, as academic research in this field evolves. How do you evaluate that, which was the focus of one of our sessions yesterday. And we have members who are experts in this area. So we feel that this is something that we could perhaps lead across the country. In terms of next generation research and development, that we have our education and career development platform, and we're so pleased to have around 40 trainees attend here today in all areas of donation and transplantation research. Could we use that as a launch pad to expand to address the national need? And then lastly, on data. So we are not, of course, in the best position to be housing mass data as CDTRP as an organization. But what we do have is that the network of users, and that's the national community of researchers. We have a developing ongoing project to establish a national specimen inventory for biobanking. Is there a connection there to biobanks and data repositories? Could CDTRP function as a support for development of research questions linked to that data? How could researchers get data out of a system, and how can they formulate questions linked to that data that are feasible? We think that CDTRP perhaps could play a supporting role there. The last phase of the research lifecycle, knowledge translation and implementation. So two of the actions that the committee recommended here. First, in terms of policy development, explore, understand, and identify gaps in the pathways that currently exist. What are the roles, more specifically, of organizations like CBS, CST, and the organizations that are really implementing that policy on the ground in the healthcare system, which are the ODOs and hospitals, and developing, how do you bridge those gaps? And then second, in terms of media and public engagement, how could we work together more effectively to build public trust, to understand how you can best reach the public and address the common goal of increasing public understanding. So I'll just say a few words about the first action here. CDTRP is, we have a mandate for research and supporting research impact. We aren't probably set up to undertake the policy development process. Other groups are probably better positioned to do that. However, the research aspects of policy development, for example, developing systematic reviews, undertaking projects to fill the research gaps that are required for policy, and really importantly, evaluating the effectiveness of policy. Those are research questions. Once you have a policy implemented, is it doing what you hoped that it would do? And we heard on the first day of the conference the imperative to do that, linked to the International Forum recommendations. So on the second point, on the media and public engagement, we have a second session immediately following this one, specifically on that point. So we can delve into that in that session. So with that, I'll welcome our panelists and would love to have their thoughts. So we'll give each panelist maybe 5 minutes for initial reactions and comments, and then open it up for a discussion. So we have Matt Weiss, who among his roles is the Medical Director of Donation Transplant Quebec. Dr. Leanne Stalker, National Director of Research for the Kidney Foundation of Canada. Dr. Sunita Mathur, who has a number of roles, but in this context is representing CST. She's the chair of the CST Research Committee. Dr. Atul Humar, Medical Director of the Multi-Organ Transplant Program at UHN. Catherine Butler, Director of Organ and Tissue Donation and Transplantation at Canadian Blood Services. And Juliana Wu, who's a director within CIHI, who is responsible for the Canadian Organ Replacement Register operations. And she leads the CIHI team for the CIHI InfoWay Joint Initiative to develop a pan-Canadian ODT data and reporting system. So welcome esteemed panelists. What an all-star group. Perhaps we'll go online first. Let's see. Why don't Catherine? Can we start with you? You're in the position on my screen. Please.
Somehow I knew that was going to happen. That's quite okay. I'm quite happy to go ahead. Patricia, thank you very much for that overview. And I'm thrilled to be here because for those of you who were at the Canadian Transplant Society's or Canadian Society of Transplantation Conference in Banff in September, would have had the opportunity to listen to several of us, talk about and support Patricia. She walked through some of the recommendations and the outputs of the ecosystem mapping that was done. And I think what struck me and what continues to strike me as a partner in the system is the complexity that this particular field faces in trying to leverage and optimize the resources available in this ecosystem, which is so small and quite niche if you look at it in the broader research realm in health sciences, or sorry, in the health system in Canada, and the complexities of trying to nail down clarity around roles and around opportunities so that we are optimizing the small group of the small amount of expertise and the deep amount of expertise that's available. What I would say, so going through some of the recommendations, and I'm not going to speak to each recommendation, of course, but broadly looking at two pieces of this, which is the role, I was asked to talk about and comment to the potential role of CDTRP as they've presented some thoughts and ideas on that, as well as how CBS can help contribute. And it's a fascinating conversation because, when we walk through those three particular areas of prioritization and execution and translation and implementation, it gave me an opportunity to think about what stakeholders and research ecosystem partners exist now that have some of the expertise and are doing some of this work in areas. And it's fascinating to look again at such a small community that's making such significant contributions with that expertise and being able to target it to multiple prongs of that particular strategy. So, already, I think Patricia, you did a fantastic job, I think, at really outlining where CDTRP brings incredible strength in the research ecosystem as it is now, and how that strength can be applied to realizing the vision that this particular report is setting forward. One of the things that, I'll comment, I think, in particular on a couple of different things. The expertise and the experience that CDTRP has in bringing ecosystem, those stakeholders together to develop to look at and explore even at a high level what some of those priorities could be is a role that I think it should absolutely continue. It is central to being able to really, I think, bring groups together to look at what a prioritization approach needs to look like for this particular system. In addition to that, the ability and the deep expertise that I have tremendous respect for with CDTRP and the work you've done in being able to bring patient families and donors to the table and to really start engaging them in this process is critical. We all know, and if we don't, we all need to be aware and should know the importance of patients and donors and families in anything that we do in this sector. Is critical and needs to inform policy. It needs to inform research priorities. It needs to inform practice, and it needs to help inform outcomes as we go forward. So CDTRP continuing to play an important space, an important role in that realm is critical. In addition to that, the one thing that I really want to tap on is the need for CDTRP to continue to engage Indigenous researchers and communities in this work, in the prioritization process, as well as in discussions around research data sovereignty. And I'm not sure if Carolyn Tate is in this meeting. She can speak to this at a far greater degree than I can and already has. But it's critical that those elements be considered. And I believe CDTRP is really well positioned to do that. Also, of course, it makes total sense in terms of the reach, the work around developing funding allocation models that are linked specifically back to the prioritization that has been identified, the prioritization needs that have been identified in some of the previous pieces. That will be, I think that the expertise again in bringing those research stakeholders together. It makes sense. It's well positioned to do that. It's well positioned to develop recommendations for a standardized approach as well. And we talked about patient family donors, all of those pieces, the developing the approach to support research in the community to include patients and families and donors in that way. The other piece too that wasn't specifically mentioned in here, Patricia, but we did talk about it a little bit and it does come out in the report. And that is the role of CDTRP. When we talk about consensus building and bringing stakeholders together, it's ensuring that we broaden that realm of research participants to include the non-traditional groups that are out there that are doing work that touches upon what we do perhaps peripherally, but have not been centrally and traditionally involved in the research. And that's the humanities, the basic social sciences, the areas that that are new and developing. Regenerative medicine was an example, I think, that was proposed. And I think it's critical that CDTRP use its skill set to continue bringing those folks into the picture and engaging them on this journey as well. I think, I'm cognizant of time. I think the area of policy development and the relationship and the role stakeholders have is a complex one for me. So I'm really glad you flagged that there's a lot of people and a lot of moving parts in that. And, how I completely agree that there is a real need in the system to have a sense of, what do we even mean by policy? What are the policy levers that are there that we have access to be able to explore and help evaluate? What are the understanding what are the critical and prioritization for evaluation needs for policy, and who needs to partner around that is a critical question. And maybe this is where I'll step into where I think other partners in the system have an opportunity to support this work. And I will speak specifically about Canadian Blood Services because we touch greatly in a number of all of these areas, but I think our strengths are probably in supporting some of the prioritization work by virtue of what we do in leading practice and engaging in our own pieces of research that are a part of this puzzle, and being able to contribute some of that expertise and learning and experience to being able to participate in a prioritization work. But I think for me, the piece that is probably even more important in terms of a contribution is the policy development work and the policy evaluation piece. There's a lot of organizations that are involved in this, and certainly by virtue of the pieces of work that we do, we have both a need and an internal goal around doing a stronger job looking at what we need to prioritize for evaluation. And it will touch upon, to a significant degree, some of those policy elements. So there's an opportunity for us to be able to partner in there to support that work. I think another area, when I go over to the realm of translation and implementation, is probably where Canadian Blood Services can help support and make the greatest, our greatest contribution would be in this area. And one of the pieces that you identified and pulled out is the media and public engagement piece, Patricia. I know that there's going to be another panel coming up on this shortly, and my colleague Peggy will be speaking on behalf of Canadian Blood Services. But we certainly have a deep and large infrastructure in Canadian Blood Services, and are on a day-to-day basis looking at how do we engage the media and the public in a different way, certainly related to the broader mandate of CBS, but we have built expertise within our own group, the Organ and Tissue Donation and Transplantation Program within CBS, that is really doing some of that work now related to media engagement and public awareness and engagement. It's a piece of our mandate that we believe could be valuable to helping realize the vision. So we're hoping and that we will be able to certainly partner in bringing that forward. We also, of course, knowledge dissemination, knowledge sharing, how that happens in the system would be an area I see Canadian Blood Services being quite well positioned and eager to participate in, again, by virtue of some of the leading practice work we do, and the fact that it both informs and provides output to the research priorities, I believe, that will ultimately be identified through this process. So I certainly don't think that's where it's limited, but the fact that we as well have developed over the years a great expertise, I think, in consensus building and collaborative partnerships. I see a huge opportunity for groups like CDTRP, CBS, CST, other professional associations, CIHI, many of the people that are representing the panel members, the patient organizations, the clinical groups, to partner in key areas of this to strengthen this vision and support the reality of, or the realization of the outputs of this report at the end of the day. So I will stop. I've probably gone over my 5 minutes, but you set us off in a great way, Patricia.
Thanks.
Thanks so much, Catherine. There's a lot to unpack there, but I will pass directly to our next panelist for her comments. Sunita, would you like to offer your thoughts?
Sure. Thanks, Patricia. And it's great to join everyone online. So today I'm in my role as the research committee chair of the CST, or the Canadian Society of Transplantation. But I know there are many members of CST in the audience and online, and I even see some of our CST staff members who have joined. So I welcome their comments in the open discussion about how CST can work with CDTRP on this research infrastructure. So the CST is actually a professional organization for transplant physicians, surgeons, healthcare professionals, but we do have a lot of overlap from our members with members of CDTRP, and a long history of working together. So these two organizations have worked together, I think, since the inception of when it was CNTRP, and that relationship has changed over time when the needs of the organization have changed. But because of this long history of working together, we do have a lot of potential to continue to collaborate on research and really come up with a cohesive approach that the CST can work with CDTRP in this area. So just going through, all the things that Patricia had raised, there are a number of kind of more straightforward, low-hanging fruit and obvious places where we could probably work together that may really kind of help us with this cohesive approach towards research. So in terms of the prioritization, CDTRP, of course, has a lot of grants and they track a lot of grants, but CST also partners on grants with CDTRP and has their own grants and does some similar work regarding tracking research that's occurring amongst our members. So there's some work that could potentially be done together to see what research is occurring in Canada, where those partnered opportunities are available. Also looking for partners and funding. That could be something that both organizations have their own ways of going about to find partners and funding, maybe working together or even keeping it separate because each organization has its own priorities, but just knowing what each organization is doing in terms of finding partnered funding and partnered grants. In terms of research prioritization, in that step, I think the CST membership, who are the healthcare professionals delivering the care to our transplant patients and families, they could really be involved with this research prioritization, and I think would be very interested in having a part in that role. So it's another place we can work together. And as well, the CST is very interested and also attempting to make some moves towards working with First Nations, Inuit, and Métis people and communities. So this could be an area where, again, a cohesive approach may be very helpful. Under the execution, I think, as Catherine also mentioned, the CDTRP has a very unique area with the patient family donors. And with them, we have CST, just even last year with our conference, had partnered with CDTRP to engage patient and family donors to the conference. It's not an area that the CST does its own work in, but it's a great area to work together because our annual meeting is like our big opportunity for knowledge translation and for planning topics that are important to the community. So I think continuing in that realm together would be great. In terms of research or development, this is another place where the CST can work with CDTRP on this priority. We do have a fellow symposium in our annual conference. We have trainee members. We also have our CST, professionals who are consumers of research and could really have some development around, what to look for in research, how to critically appraise research. So there's a lot of areas there that we could work together. And of course, our annual conference, which is a large conference done every year, big knowledge translation event where CDTRP has been involved, but we could strengthen that and work together in that conference a little bit more. And then finally, I'll just talk about the implementation. And I think the big one is under the policy development. So the CST does develop position statements, guideline statements, information papers that are done by various professionals in that group who bring their own research expertise to develop those documents, and then they're made available both in the published literature, but also to the CST members. This could be an area where I think the CST could really help work with the CDTRP in this area of policy development, because we do have all the clinicians, potential policymakers, administrators of transplant programs, medical directors of transplant programs are there as CST members. So I think this is an area where we can really engage together. And in terms of the media and public engagement, I think, when the media is looking for people to speak about topics in transplant, they probably do turn to a large professional organization like the CST. So again, having a common message, common voice, finding people to speak, always consult. We can consult with CDTRP about who are the researchers doing this work if it's beyond our own membership. So that's another area that I feel we can definitely work together. So I just also wanted to mention that the CST, being a large organization, has a number of subcommittees. So there's a number of smaller groups within the CST that probably can engage more specifically with the CDTRP. So we have the research committee, which I'm representing today. We have a grants and awards committee that adjudicates the actual funding. We have an education committee that could be involved with, dissemination. And we also have our annual scientific conference planning committee, which I know Patricia does sit on, which is great. But having that link with CDTRP for that large event is also really important. And I think those are sort of the contributions that I could see right away. But as I said, there's many members of CST in the room and online today, and I appreciate hearing their comments as well. So thank you.
Thank you. Thank you very much, Sunita. Juliana, take it away.
Sure. Well, thank you, everybody, and good morning. Very happy to join you all from CIHI, or the Canadian Institute for Health Information. So maybe thinking a little bit about how CIHI can partner with this community and with CDTRP, I think it's really about data. So as background, CIHI is a pan-Canadian data organization. Our mandate is to collect, to curate, and then disseminate data to inform evidence-based policies and programs. So with our mandate, we do host an extensive set of data assets across the healthcare continuum. They're all linkable. And in addition to that, we also have health workforce data, spending data, patient-reported data. And so, as Patricia's already mentioned, currently we hold the core of the Canadian Organ Replacement Register, which is where we collect data on organ replacement therapies around dialysis for patients who have end-stage kidney disease. And then we also collect data on solid organ transplant and donation activities. And we're also partnering with InfoWay and funded by Health Canada to build a new data and performance reporting system that would leverage some of the modern digital health solution and integration capabilities, with the goal that eventually, data creation would be more timely, would be more seamless, but also the management and access to data, including access by researchers, would be easier as well, right? So thinking about that and thinking about kind of CIHI's role and also CDTRP's role and what we nowadays kind of like to term as a learning health system, how do we fit together, right? So CIHI has data and CIHI reports on this data, which then can really kind of feed some of the prioritization activity that CDTRP and others in this area can think about, right? Like essentially our reporting can help inform where are the gaps and where the opportunities that then research and innovation can feed information into. So it's almost like a nice, we all play kind of, different roles within this ecosystem. Thinking about also researcher access to data, right? So ideally, we like to be able to have a system where data that is already existing, right? Administrative data can be leveraged to its fullest potential. So thinking about core data today, what we have at CIHI is linkable to the person's hospital data, for instance, and then we can look at outcomes with these patients as they go through the donation and transplantation journey. And we can also look at costs of treatment associated with these population as well, right? So thinking about just leveraging what's already existing can be very efficient and effective for this system. Thinking about what, in terms of what data to be collected and to be shared moving forward, CIHI is very keen to work with this community to understand, where are the data needs, right? We just completed the exercise for the new data system in terms of developing minimum data sets for disease donation, for living donation, for transplantation. And each of those minimum data sets also comes with standards, because data standards is what allows data to be more comparable when it's actually being used and analyzed, right? So we are in this space of really wanting to speak to this community and work with the people that we already have a relationship with, such as CDTRP, to understand data needs and to come up with standardized data collection that can be used for system performance analysis, but also for research purposes as well. The other interesting thing I think, Patricia, you mentioned is the ongoing work to engage with the Indigenous community as well as with the patient and people with lived experiences, right? And that's area that CIHI has been involved in as well, and it's really like to kind of share our learnings with CDTRP and learn about each other's best practices. On the Indigenous data sovereignty side, as Catherine mentioned, it's really important and kind of something very important for CIHI to engage with and to do well. So we have been engaging with different Indigenous communities, understanding how we can best manage the data that we have. A lot of the data assets do have Indigenous identifiable data in them. So making sure that we are managing that data and providing access to such data in a responsible and respectful way. So that's an area that we've been working with, and I think that's an area that really ties closely to the research community, right? Because how do we how does CIHI in a responsible way provide access to researchers to the indigenous identifiable data in a meaningful and responsible way? As well, like in our work, we've also been involved in working more with families and patients and people with lived experiences. And so we're learning a lot in terms of how to engage with them as well. Again, more from a system performance reporting perspective, but I think there's probably shared learnings that can be equally helpful for all of us within the community. And then the other thing I would just kind of also add as well is, CIHI is also a member of the Health Data Research Network Canada. I don't know how many people in the audience is familiar with that, but the Health Data Research Network Canada is a network of organizations that consists of pan-Canadian organizations such as CIHI and Statistics Canada, but also the provincial data centers such as ICES in Ontario, Population Health Data BC. And this network is also thinking very much along these lines, around, how do we do public engagement, patient engagement, and Indigenous engagement, and in a collectively in the right way, but also in the most meaningful way, right? And I think there's probably opportunities and I'm happy to make the connection, right, between CDTRP and Health Data Research Network Canada to leverage, each of the groups' work, because I can see that a lot of different groups are doing very similar things, and just even that information sharing and knowing where each other are may be very helpful. So maybe I'll leave it at that and turn it to my other colleagues.
Thank you very much, Juliana. Atul, would you like to go next?
Sure. Thank you very much. Hello, everybody, and thank you for the opportunity to speak today. So I'll try to keep it brief. I feel like we might be running a bit over time. So first of all, I want to congratulate CDTRP on this process. I think it's excellent, and it's very timely because it's a very exciting time to be in transplantation, because we're kind of seeing a convergence of all these new technologies that are really going to change things. And if we want to be right at the center of that change, I think we have to do it together and with a unified vision. So I'm going to try to focus my comments on how, as the head of a big transplant center, how we kind of intersect with these three priorities that are proposed. So the first theme was prioritization, and I think there what stood out for me is that learning from our patients what's important to them, and I feel that we kind of lack doing that, especially at the center level. And I think the CDTRP has really excelled at engaging patients and families and donors. So, where we can help as a transplant center is really contribute to identifying those patients that would be very engaged in this process and would be best suited to provide input, and then refer those on to the CDTRP and so that they can be engaged in that process. The second theme that kind of emerged from this is execution, and I think that's really clearly important to do this at a national level. I mean, we see, one of the limitations with transplant is we're dealing with small sample sizes and relatively small sets of data, which are not great for really impactful, meaningful research projects. And I think there having a national framework is helpful. The other part of this that resonated with me was the next generation and supporting the next generation research development. And I think that's actually a risk for our community. And I think we really need to probably do more to ensure that transplant in general is a field that's more attractive to the younger generation. And that's, I think, particularly challenging as we go to, the importance of work-life balance, and transplant traditionally hasn't been great for work-life balance. And we know that the funding environment nationally for transplant is quite poor as well. So I think where the transplant centers can play a pivotal role here is really fostering this next generation, right? They have access to the students, they can facilitate the interest, and they hopefully have access to local funds to support some of these early career researchers and really get them plugged into the CDTRP and other national efforts. In the execution theme, I also just wanted to briefly highlight the real importance of philanthropy. I don't think that's really been mentioned. And this, of course, I think tends to be most successful at the local transplant center level, often with grateful patients. But, there's huge, immense potential to this. And, you can really make meaningful investments in things like high risk, high reward research, bridge funding, women in transplantation, other key priorities that then could be leveraged up to the national level. And I think we could also help programs across the country do a better job of fundraising, because I recognize it's not as successful at every single program out there across the country. And then finally, I just, on the last theme of translation and implementation, I just want to really highlight the success we had with COVID. You know, all of us at the center level, I think we're frustrated and struggling with our provincial governments because they weren't giving us vaccines for our patients. They weren't allowing access to therapeutics. And it was really only after we came together at the national level and developed guidelines and policies that we could then take to the provincial governments, and that made a huge difference to our patients, actually. So I think if we could look at ways to recreate and improve that process for policy development, across the transplant spectrum, that would be very helpful. So I think I'll stop there, and thank you for allowing me to contribute to this process.
Thank you very much, Atul. Some great ideas there. Our panelists in person, I see, did you volunteer to speak first, Matt? That's what I saw the hand gesture. Go ahead, Leanne, please.
So first of all, thank you very much for inviting me to be here. This is the second time I've sat on this panel, and I really appreciate it. And a shout out as well to CDTRP for all the work they did to put this together. It was fantastic to participate in. So before I get started, and I'll be quick as well, we've had a lot of great ideas from the other panelists that are very similar to some of the things I was going to talk about, but I wanted to give a 2-second intro of why I'm here. So like why I'm sitting on this panel. I'm a little bit different than some of the other voices that have been heard today, because I am actually coming from an organ specific lens rather than a transplant specific lens. So I'm here representing the Kidney Foundation. We know that kidney transplant represents a very high percentage of transplants that are done nationally, but our focus is still on an organ specific space rather than on sort of transplant on a whole. And I think that that's important because it changes the lens that we're coming at this with. I'm also here as a patient community advocate lens. Our role is as a patient organization. So we had a lot of conversations here about how to incorporate the patient and community voice into everything that we do, something that CDTRP does fantastically well in the research space. And that really is our #1 priority, is making sure that our patients and community is getting the best care, the best research, and being advocated for. Personally, I'm also a basic researcher. So I think it's really important that we continue to have that basic researcher lens, ensure that we have support for development of research projects, all the way from the very basic principles, all the way through to our clinical trials and implementation. So I really come at it from that side. We also administer a capacity building training program for the next generation of kidney scientists, which would be very similar to sort of talking about some of the things, how do we foster the next generation? And that's something we come to this with experience in. We're also a funder, so it's a big space, right? We're one of the people at the table here that are providing funding for big research projects, of which transplant is one of the many topics that we support. And we also have experience in advocating for our patient communities and our families and translating into policy. So there's been a lot of conversations about how do we make sure we get this work through the whole continuum of the spectrum, right? We have to foster the next generation to want to stay in transplant. We have to teach people how to do good research. We have to then support that research with money. We have to give them access to samples and data and conversation and, access to an equitable lens. We then have to be able to take that and translate that into real results, whether it be in clinical practice, in government policy, or otherwise. And this is something that the not-for-profit sector does every day, right? We already have the full spectrum of that space. So, we're here to help. So I think, a lot of my fellow panelists have touched on a lot of these things, but we were asked to discuss what role could CDTRP play in this space. So we've all acknowledged this is a space that has a bit of a lack of a cohesive ecosystem. We know that, right? We know that it's a bit piecemeal. I fund some transplant grants, CIHR funds some transplant grants in multiple different spaces. But I think that CDTRP is already doing something really important here, and that is that they support research, they communicate research, and they're centralizing priorities and communicating impact without dictating the direction of that research. So that's that's a piece that's really important when you're coming from a funder that's organ specific, right? I don't want somebody telling me what I have to fund because I have my own priorities for my donors and for my community. But having a centralized core that can really help to accelerate impact by providing support, by providing capacity for programs and centralizing what's being done is really useful. It's really useful for all of us, right? It doesn't affect our organizational mandates or our organizational requirements, but still allows us to communicate in a transparent way about what is going on in this space, making sure that there's no overlaps. So I think that that's something that CDTRP is already doing a fantastic job at, really with very little resource based on the amount of projects and the amount of work they do. So really maintaining that connection, the engagement with the different communities that have already been mentioned, the patient families and donors, the Indigenous space, and continuing to do some of that in a more centralized way, I think is really going to be key to moving this forward. The only other thing I wanted to sort of mention is we always come back on these projects to like, this is all fine and well, and this is great, but who's going to pay for it, right? I mean, we always talk about that, who's going to pay for it, where's the money going to come from? But I think that there's a lot of steps we can take, as CDTRP has handily demonstrated over the last couple of years. There's a lot of things beyond money that can help motivate, move, and support research in a way that's cohesive. There's a lot of ways to redefine excellence, to work to change the landscape. CDTRP is doing a lot of work, as are we, as are the organizations that are sitting on this panel today. And if we can all come to the table together and decide how we want to do that in a centralized way, I think we can take some bigger steps. I would really encourage the group to leverage the experience that our sector already has, right? We already have a lot of advocacy and policy experience. Leverage that. Just because we do it for kidneys in specific, there's a lot of organ specific groups out there. We've already done this. We know how to do it. We as Atul mentioned, we also played a major role in advocating over COVID for vaccine changes for our communities. Let us continue to do that, right? Let us continue to help and play in that space. And we're happy to be here and we're happy to contribute. And I think that, it's not going to be a simple road. We know how long it took to get this going, but the fact that we're at this point really is amazing. So I think we all need to continue to sit at the table together for the next steps. Make sure we maintain the priorities of the individual players at the table so nobody starts to feel, toe-stepped. And move forward for a better future to make sure transplant is still being prioritized. So,
thank you very much, Leanne. Matt, last panelist, and then we'll have just a few minutes for questions and discussion after that.
Thanks for that, and I'll make sure to talk just long enough so Heather can't ask a question. And also as someone who is very interested in policy research, all the discussion of it has it's got my heart aflutter. And for any funders who are listening, the address for the checks is 3-88. No, but I think as I've been listening through this, I've really been thinking about some aspects of my clinical work. And for anyone who has ever responded to a code blue or a resuscitation on the ward, knows that there can be a lot of chaos. You might have 3 or 4 people trying to attach the sat monitor to measure the oxygen saturation, while no one has actually got the bag and the mask that are going to bring that saturation up. And when I'm training people how to deal with that, clarity of roles is one of the key things. You have to know what you're supposed to do in those situations. And as we have gone through this process with the collaborative and with the redefinition of the CDTRP, the clarifying the roles of the various groups that are involved. So CBS in the policy development, CST in the professional development and the dissemination of research, primary investigators like Atul, who are generating the knowledge, and Juliana with the data group. Those are great roles. And the role of the CDTRP is an ongoing discussion that we have to define what we do well, what we bring to that table, and provide those services in a way that is meaningful. And those services that we can provide can be both tangible and intangible. So tangible, the massive network of PFDs that makes it where a researcher doesn't have to go out and build that themselves. They can partner with the CDTRP create that. Having a dissemination network, having training so that their trainees have a network of other people that are training them in a multidisciplinary fashion, learning about things that they wouldn't necessarily learn about in the own investigator's lab. That is a massive tangible benefit that CDTRP can offer. And intangible does not mean unimportant. We're here in a big way because we're passionate about the CDTRP. And that passion brings us into the room together, sparks conversations about new project, new ideas. I mean, I'm going to be going home with far more ideas than I'm going to have time to address. Some of them will turn into projects and outputs that will really make a tangible difference. So keeping those priorities and understanding the roles of everybody is going to be a very important process going forward. So I just, for those on the call that are listening and from the collaborative, making sure that the CDTRP is mandated with a role in that ecosystem, and making sure that the other, that the role of the CDTRP to interact with CIHI, to use the data that's going to be generated, to generate knowledge, to give to CST to disseminate to their members, to feed the policy development CBS, and then to feed back to the CDTRP to evaluate those policies, all the while having researchers feed new ideas, interacting with the Kidney Foundation and other organ-specific groups to generate priorities. These are things that I can really see the ecosystem working harmoniously on. So I guess I would close with that. And thanks for everybody here who is, struggling with the residual toxins of fermented grape juice from last night.
Thank you, Matt. Okay, so we do have a few minutes for questions and discussions. There's been a lot put on the table, so it's hard to know where to start. But maybe we'll pause, let people gather their thoughts, and if there's comments online or questions and thoughts from those here with us in the audience, please don't be shy. Or if any of our panelists would like to pick up on ideas that others have shared. Lori.
So this has been really, really helpful. I'm just recognizing that the ecosystem of organ donation and transplantation probably doesn't include one of the key players that was mandated into CNTRP by CIHR in the very beginning, and that's our stem cell transplant counterparts. That's a whole piece that is part of our ecosystem that doesn't necessarily overlap with the ODT only ecosystem. And I'm just aware that those are also parts of the conversation that we need to keep in mind. I'm also cognizant of Leanne's comments about the importance to all of us of embedding fundamental basic research in the research spectrum of what we do, because that is not going to be driven by necessarily by the clinical work that we do, but by other factors that include curiosity and science and so on. So I think those are elements that we really need to make sure are covered. But I think the coordination of all these things together, that's what I'm hearing over and over again from almost everybody, is that the central coordination of all these efforts across the country is something that's very helpful. And I think that gives us also opportunities internationally that we find harder to do because sometimes because of the provincial nature of healthcare in Canada. But there are these national organizations and national efforts, and coordinating those allows us a more powerful voice to engage in important international research in donation and transplantation. So thanks to everybody for these really helpful comments. Can I comment?
Yes, please, Leanne, you want to respond?
It's not really a response. It's more just an addition to that. I think there's more than just, I'm a biochemist, so I am all for the basic science. I think it's more than just the basic science, though. I think the other piece that we often forget about or don't talk about is what happens on either end of donation and transplant. So we have sort of a window in the middle right now that we're talking about a lot, and whether that's, from the donation to transplant space, but we also have a whole disease space in front of donation and transplant that is also really intimately linked to this situation, right? People don't just get a transplant for no reason. They're getting a transplant because they've developed a disease type or something has happened before that point. So all of the kidney disease research, all the heart disease research, all the cardiovascular research with lungs, all the liver research, these things are still very important because ideally we would like to prevent people from getting sick, right, in the first place. So I think that those prevention pieces and specific pieces are important. And then on the other end of that, we have our long-term outcomes question that we often don't look at, right? We often say, oh, you get the transplant, and we've talked about this a lot. The transplant's not a cure, right? We still have, we have to look at medication. We have to look at wellness. We have to look at quality of life. And I think those are the pieces that are often missed. So we have to remember that this continuum is much longer than we may often sort of sit that window in, which makes our lives more complicated, I suppose. But it also gives us a lot of opportunity, and we shouldn't forget those opportunities when we're bringing people to the table.
Tom, please go ahead.
Yeah, I just want to thank all the panelists for their contributions, and you know, what I was reflecting on when I was hearing all of this was the, you know, what is the real, what are, I mean, I don't want to say the real strength of the CDTRP because there's so many, but you know, core to its mission is to actually bring all of these diverse communities of experts. And I'm looking at the panel here and seeing all the different sort of aspects of the ecosystem that are represented in the panel as well as in this room. And really, you know, for the future of the CDTRP, it really has to be to continue to be that catalyst for research, for change. You know, all of these groups coming into one place, there's a little reaction chamber of what happens when we discuss those ideas, and then it goes out and produces something new. And that's what we've been doing for the last 10 years. And I think it's really important to think about how we can continue to do that. And fundamentally, it's about bringing people together. You know, there's only so much we can do kind of in our own little silos, and it's bringing those communities together and having them interact on an ongoing basis that I think is really critical to what we will continue to be successful at in the future. And it's going to look different in the next 10 years than it did in the last 10 years because the realities on the ground have changed, and so the needs have changed. But having that role to bring all those communities, whether it's the stem cell community or the donation community or patient partners or Indigenous communities, how we bring those things together, I think is going to be critical to the mission. And how we can bring the funding and the innovation and the investments to bear on that mission, I think is going to be the major challenge.
Mm-hmm. Thank you, Tom. I see we'll have our one last question from Murray Wilson. I see you've got your hand up, Murray. Please, your question, and then we'll wrap it up.
My question, maybe to the panel that's still sitting there, is from a point of view of the uses of nomenclature. When one uses the word optimization and one uses the word prioritization, is that sort of the Noam Chomsky view of those words? Is it a scientific view? Is it a view that the press and the public appreciate in the same manner that your cohorts do? I think the use of English about analytics is a really important part of our story going forward. And I'd just like to add one more point on venture grants. I'm also on the board of the Transplant Research Foundation of BC, and I wish that Christy Caldwell was on the line so she could correct me if I'm wrong. I think in the 3 years before COVID, we put out $300,000 worth of venture grants and mini grants, and not all of them are successful, but those translated into more than $20 million from 300,000 into $20 million of conventional grants. I think the venture grant approach is absolutely spectacular, and I think it should be expanded. Maybe that's a question, maybe that's a suggestion. Sorry to take up your time.
Thank you very much, Marie. And is indeed, as Sandra points out in the chat, Christy's not here because it's her birthday today. Happy birthday, Christy. Thank you. So we've come to the end of our time. This is an ongoing conversation with a lot of pieces in it. So thank you to all of our panelists for helping us move this along, and really looking forward to evolving the discussion and really moving into the action phase. How do we start undertaking some of these things as a collective, with each of us playing the roles that we are well positioned to do.